Okay, thank you so much, everyone, for coming to this meeting. We're so excited to have Dr. Sheng here with us today, one of the leading experts in sports ultrasound. So before we get started, I just want to start off with some introductions. My name is Renee. I'm a MS2 member at large, and I'm a third-year medical student at UCLA. And co-moderating with me today is Robby here.
Hey guys, I'm Robby. I'm the MS1 at large member of the MSIG group, and I am now a second-year student at Midwestern in Arizona.
Yeah, so Robby and I will be your co-mods for today. Dr. Sheng is kindly here with us to talk tonight about sports ultrasound, and afterwards we'll have some time for Q&A, but if you have any questions throughout, feel free to put them in the chat as well. So I'll start off by introducing Dr. Sheng.
Medical students are...
Oh, okay. So Dr. Dana Sheng is a sports medicine physician with Mercy Medical Group and Dignity Health Medical Foundation. She completed her medical school training at Georgetown University School of Medicine, residency in physical medicine and rehab at UC Davis, and her sports medicine fellowship at Northwestern Lurie Children's Hospital. She was the fellow liaison for the AMSSM Education Committee and currently serves on the Sports Ultrasound Committee. Dr. Sheng has presented at AMSSM, ACSM, IADMS, and PAMA. Her sideline medical coverage experience includes UC Davis and Northwestern University Collegiate, De La Salle High School, adaptive sporting events, the California International and Chicago Marathons, NCAA March Madness, and USA Gymnastics. She's also passionate about performing arts medicine. In her free time, she enjoys dancing and traveling the world. So we're so excited to have you tonight, and I'll hand it off to you.
Thank you, Renee, and thank you all for having me here. There's a lot to cover. Hopefully we have enough time. Otherwise, you can always send out the information. But yeah, excited to get started. So let me share my screen. So do you see only my slides?
Yes, we can see your slides and then the little bar at the top.
Okay, all right. So I have no disclosures. This is an overview of what I'm going to cover. I was told that many here will have a basic idea of some general ultrasound basics and that it has become a more prominent aspect of medical school education, which is awesome, and you guys are so lucky to have. And so with that, I'm going to cover some of the basics and then delve into normal versus abnormal structures on ultrasound, sideline applications, etc., as requested. And if you would like more basics or a refresher on those, then I highly recommend one of the AMSSM videos, The Principles of Sports Ultrasound and Introduction to Scanning Techniques. So a little bit of a background on ultrasound. So first, what is it? You use reflected ultrasound waves to obtain images of the musculoskeletal system, so soft tissue, bone, joints, extra-articular and intra-articular. But as we will see, we can use this beyond the MSK system as well. And it can be an excellent diagnostic and procedural tool. So with ultrasound, you can identify your injured or symptomatic structure, grade the severity of the injury, direct specialized treatment to that specific area of injury, and then follow your patient's rehab progression. So some pros and cons. Ultrasound has several advantages, including the ability to perform dynamic evaluation. So you can look at active movement. For example, if a patient has peroneal subluxation during active ankle range of motion, you can do stress maneuvers, putting stress on a joint to widen it and see if there's ligamentous injury, like to your ATFL, and then can also allow for a faster diagnosis. Additional information can be gained from some tools with ultrasound like Doppler imaging. You can use your sonopalpation, so pressing with the ultrasound and seeing where the patient has pain. You can also split your screen and do side-by-side comparison, looking at left versus right, or looking at older images versus today's to see the difference on follow-up. And then there's also an extended field of view, so you can see the entire length, for example, of the Achilles in one view, which is really nice. Some other pros are it's less expensive, it's more portable, for example, in clinic and on the sidelines. And then there's less metal artifact compared to other imaging modalities. And of course, its ability to guide procedures. As for cons, there are not many, but it is operator dependent. And while ultrasound can have great resolution for more superficial structures, the deeper structures, joints, bones, give you a little limited of evaluation because of the limited penetration. So important to recognize your own limits and the limits of the machine. So compared to other compared to other injection methods, including palpation or landmark guided and fluoro, ultrasound guided injections have superior accuracy for upper and lower extremity injections, all in the 90s to 100% and significantly higher than the other methods that are listed here. In addition, your ultrasound guided procedures have improved pain reduction, improved patient function, and decreased patient care costs. All good things. This is a table that I created that is by no means comprehensive, but it's a summary of the sensitivity and specificity of ultrasound and other imaging methods for some diagnoses within sports medicine based on some studies and review papers. Although I did not see many listing numbers for more than one of these modalities in the same study or review, but the pattern here is that ultrasound can be as good as, if not better, than X-ray, MRI, CT. And this is a general list of indications which overlaps with the pros and benefits. So it's very useful for diagnostic injections to determine the structure that the patient's symptoms are coming from, especially when you are stuck between two and they're very closely located to each other. Also used to guide your injections, especially to deep structures or when there are structures nearby that you don't want to hit, for example, vessels, lungs. Also for dynamic evaluation, as I mentioned before, for example, if they say they hurt only during a specific maneuver, then you can look at that under ultrasound. Also allows efficient diagnosis. And then you can also use it to avoid issues that come with other imaging modalities like metal artifact and radiation. There are no absolute contraindications for an ultrasound exam, but just remember, as before, be cognizant of / remember your own limits and the machine's limits, and then don't inject infected areas and don't aspirate or inject suspicious masses. So a few ultrasound basics. For terminology, on ultrasound, the images are grayscale and they vary based on the density of the tissue. So anechoic tissues look completely dark as no waves are reflected back to the probe. And this is seen with cartilage and fluid. Isoechoic refers to something with the same echogenicity or reflectiveness as something else that you're referring to. Hypoechoic structures are relatively darker and result from a low amount of reflection. Hyperechoic structures are relatively brighter from higher reflection. And then structures can also be mixed echogenicity or have components that are hypo and hyperechoic. So let's say that this middle gray one is the average or reference echogenicity. Then the one on the left is going to be virtually anechoic. This one would be hypoechoic, and then both of these would be hyperechoic. So for probes, you're going to have a few different options here. You're going to have some that are higher frequency, which is higher resolution, but less penetration. There is lower frequency, so lower resolution, but higher penetration. There is on the screen, A is the linear probe, B is the curvilinear, and C is the hockey stick. So A is kind of your most general one that you can use. It's good for superficial and medium depth structures and has higher resolution than the curvilinear, although the curvilinear has the deeper penetration. So good for the hip joint, shoulder joint, especially in someone who may be a larger body habitus. And then the one in C is the hockey stick or the compact linear probe. So that's good for really small superficial structures like in the hand and fingers, but it also has a smaller footprint. Couple quick notes on using the probe. You want your hand to be resting in contact with the patient. This will allow some fine motor adjustment in your probe pressure and positioning and also be more comfortable for you. Now on to what some normal and abnormal structures look like under ultrasound. So here we'll go over different structure layers and their echogenicity. I'm going to follow the numbers from top to bottom of the screen, not from the 1 to 7. So 3 is going to be the skin, and it's slightly hyperechoic. 4 is going to be your subcutaneous fat, and it's heterogeneous or slightly hypoechoic with hyperechoic septae. And then 5 is your muscle. So this is hypoechoic with hyperechoic septae. 7 here is your joint hyaline cartilage, and that is hypo or anechoic. 2 here is your bone cortical surface, and that is hyperechoic. 1 is your soft tissue here, fat pad, and that is isoechoic. And then 6 here is some intra-articular fluid that is anechoic. And then finally, this one is just the area under the bone that you can't visualize, and so that looks anechoic. And now we're going to look at some layer types individually. So starting with muscle, here we are looking at the proximal calf in both short axis and long axis. So remember, the muscle has a hypoechoic appearance with hyperechoic intermuscular septae here, here, here between the gastrocs and the soleus, and also the perimysium, or these brighter lines and dots here. So in the short axis here, you're going to see this, what we call the starry night appearance. And then in the long axis, you're going to have these kind of feather looking or veins on a leaf appearance. And I'd say in this example, it looks a bit more leafy, but in some other images later, I'll show one that looks more like feathery. So in this slide, I've put tendon and nerve together because they can sometimes look similar, and I have images of them together. So these images are of the palmar wrist, where the image on the left is long axis, and then on the right is short axis. So in both of these images, one is going to be the median nerve here and here. And then 2 in both of these images is the flexor digitorum. There's the superficialis and the profundus. And these are scattered here, and I haven't included all of them, but this is one of those tendons. So you can see they're kind of similar looking, but tendons are hyperechoic, nerves are mixed echogenicity. And you might notice that the description of the echotexture of tendons and nerves in long axis is literally a description of their architecture. So the appearance of tendons in long axis is described as fibrillar. So it's like seeing lots of fibers together. And in short axis, it's described as a broom end. So it's like if you're looking at the broom from the bottom, so it's like all these bristles here. And then the appearance of nerves is described as fascicular in long axis because you have these hypoechoic nerve fascicles that are surrounded by hyperechoic connective tissue. And then in short axis, it's described as this honeycomb kind of appearance. So ligaments are hyperechoic, and like tendons, they also are described as fibrillar, although they have less of that kind of appearance compared to tendons, and they attach to bone on both ends. So in this example, we're scanning the medial joint line in long axis, and we see the femur here, the tibia, and then the MCL is connecting to both of those. And you can appreciate some of this fibrillar appearance. And note that during scanning, you can put stress on the joint here so you can assess whether the MCL is intact. So here we're showing 2 types of cartilage. On the left, we have the femoral trochlea and the articular hyaline cartilage here, that anechoic space, and it should be uniformly thick. And on the right side, we have the shoulder glenohumeral joint. So we have the glenoid here, the humeral head here, and then this labral fibrocartilage is this hyperechoic triangle in there. So this is a scan of a pediatric patient's shoulder. We have the humeral head here and the glenoid here. And there's a line in here as they scan that could very well be confused for a fracture, but it's a growth plate actually. So if we get a still from that, then that's shown here. So not a fracture, it's normal for kids or anyone who hasn't closed their growth plates yet. So next is vessels. They are anechoic and round. So to differentiate between arteries and veins, you can look at the pulsatility and the compressibility. The arteries are more pulsatile and less compressible compared to veins. In addition to this, you can look at the vascular flow on Doppler, and you see that the flow is more turbulent for arteries. And on this example Doppler, the artery one is red and the vein is blue. But when it's more turbulent, you can actually see kind of multiple colors for the artery one. In any case, if you see any fluid on a scan that you are not expecting, you should check and see if it has any Doppler activity. And just so you know, for this short axis images, they are of the IG or IJ vein in blue and the carotid artery in red. So there are a number of common sonographic artifacts, and you've probably talked about them, but I wanted to focus on one that I feel may be the most important to recognize first, and the rest are covered in the AMSSM video that I mentioned before. So anisotropy is an artifact that happens if the structure that you're focusing on is not parallel to the probe, so the waves do not reflect back to the transducer, causing that structure to appear hypoechoic in that spot. So tendons can be very subject to anisotropy, and this artifact affects ligaments and tendons more than muscles and more than nerves. Here we have the long head of the biceps tendon in long axis view. So remember that the proximal part of that tendon is a little more anterior than the distal part, so you have to adjust the probe when to make it more parallel to the distal part. Otherwise, you'll end up having an image that looks more like this side, where it looks like part of the tendon is either missing or damaged, and you want it to look like this side where it's pretty uniform. This is another example of anisotropy. So you're looking at the supraspinatus tendon in long axis view for both of these. And you have to remember that the distal part here curves, so the sound waves won't hit the distal fibers the same way. So if you don't remember that, you might think you have a little tear here, but you should try and make that come into view so you can confirm that you don't actually have any tear in there. So now for some uses for sports ultrasound on the sidelines. So first we can assess for muscle injury. So here in long axis, we can see more of that feather-like appearance of muscle in long axis, although there are some abnormalities in both of these images. Both of these demonstrate a tear in the medial gastroc. The top image is an acute tear. So you see some mostly hypoechoic defects with some retraction of muscle fibers. And then this bottom image is a more remote tear. So you see a hyperechoic scar and some disorganization of the normal fiber arrangement compared to these lines here. And then you can also assess for tendon injury. So here we're giving the example of the Achilles. So you scan for that with the patient prone here. This is the normal Achilles in long axis. And then on this side, in comparison, and this is an extended field of view, by the way, you see that there's a focal anechoic fiber disruption here, consistent with an Achilles tear, with associated distal tendinosis as evidenced by this thickening, kind of compared to this part, and then mixed but mostly hypoechogenicity here. And then next we can look for ligamentous injury. Here we're looking at the lateral ankle just anterior to the distal fibula at the ATFL, which is a super common area of injury. So on the left here, we have normal image of the ATFL between the fibula and the talus. So on the right, there is discontinuity here of the ATFL consistent with a sprain. So similar to tendon injuries, you can see thickening and hypoechogenicity. And then remember, you can also apply stress to the ligament here, so you can differentiate between different grades of a tear. Ultrasound can also assess cartilage, and that includes fibrocartilage like the meniscus. So on the left here, we have the medial meniscus as this triangle shape between the femur and the tibia, and it's deep to the MCL, which remember has 2 layers. So there's this deeper layer and then this superficial layer. And then on the right side here, we have a focal hypoechoic vertical cleft in this view that extends to the articular surface. So that's consistent with a horizontal meniscus tear. Ultrasound can be used to diagnose fractures. And here I have an example of a first rib stress fracture seen on the left. So you see this focal disruption of the cortex, you can call it step off as well, and then sharp edges at the break. And then you can also use ultrasound to follow your fracture healing. And as you can see from this image on the right, you see on repeat ultrasound that there's this callus that has formed overlying the fracture site, and that's consistent with healing. You can also assess abnormal fluid, and these are all cases of prepatellar bursitis. So in these images, the patella is here, here, and here. You have your skin and your subq up here, and up here, and in between is the bursa that is enlarged in all of these views. In this one, it's purely anechoic, and these have mostly hypoechoic, but kind of mixed echogenicity. And then on this side, you just see from this extended field of view how far this bursa kind of extends. I have not personally used ultrasound to diagnose dislocations, but it has been done and has been used successfully in the emergency setting. So this view is a posterior view of the glenohumeral joint, where you have the glenoid here and the humeral head here, and this is a posterior view of the glenohumeral joint. And your humeral head should be well located within the glenoid. And if this is out of position, then you can tell by how superficial or close to the probe. Remember, the probe is posterior, so versus deep or anterior, where the dislocation is. And then this was the image that was labeled. So in addition to these bony landmarks, we also have the scapular spine, your infraspinatus, and on top of that is the deltoid. So here in neither case is the humeral head appropriately aligned within the glenoid. And you can see on the left side that the humeral head is deeper from where you're scanning in the posterior shoulder. So it means it's an anterior dislocation. And then on the right side, you see the humeral head is closer to the surface or closer to where you're scanning from the posterior shoulder. So that is a posterior dislocation. And you know that the humeral head kind of obscures part of the glenoid view here. All right, so growth plates, injuries there can also be visualized. So this is a case of a little leaguer shoulder, which is an overuse injury that occurs in young baseball pitchers, and this causes widening of the proximal humerus growth plate. So remember that the growth plate, or the physis, is between the metaphysis and the epiphysis. And you can see here there is jagged morphology that could otherwise be mistaken as a fracture. There is a growth plate injury here though. So you can see that the right side, the throwing side versus the left non-throwing side, the distance between the metaphysis and the epiphysis, or the width of the physis, is widened on this side 3.8 millimeters versus 1.9 millimeters on the unaffected side. Sports ultrasound can also diagnose Morel Lavallée lesions. So this is a closed degloving soft tissue injury from shearing or separation of the skin and the subq tissue from the underlying fascia. So this image was taken from a soccer player who was having knee pain and swelling, and ultrasound revealed this large, isolated and discrete hypoechoic mass separating the tissue planes between the subq tissue and the intermedial aspect of the knee in the VMO fascial plane. So this athlete got ultrasound guided aspiration, triamcinolone injection, ACE wrapping, and then a protected weight bearing plan to allow this lesion to sclerodes. And this is the needle that was done for used for the aspiration. And of course, you guys are probably very familiar with the FAST exam with these 4 primary views looking for pathological fluid and potential spaces. So I'm not going to go into too much detail about that, but just note these can require bleeding up to 200 cc's or more before the blood can be visualized. Again, kind of operator dependent, but goal is to be really helpful in these emergency situations. All right, so this is a little bit more obscure or less popular of a application for ultrasound, just because it's not very commonly taught probably in sports medicine, but you can look at vocal cord dysfunction. So you have pathological closure of the vocal cords while you're breathing in, and this can be visualized on ultrasound. So in this image, you're looking at the arrows are pointing to the vocal cords here. The ovals are the arytenoid cartilage, and then the stars here are the thyroid cartilage. So this is normal, where you have the abducted position of the vocal cords, and this is the abnormal or the VCD pathology. So you see these vocal cords are adducted here compared to abducted over here. And that's really the main finding. All right, so I thought this was cool. I also have not seen too much of this, but I think it's a great application. So it's ocular ultrasound, fast, simple, can help differentiate between various ophthalmologic emergencies. So indications are if you have eye pain, acute change in vision, eye trauma, if you suspect there's increased intracranial pressure, and then if you have so much swelling or bruising around the periorbital tissue that you can't directly visualize the eye, but do not scan if you are concerned that there has been globe rupture, because you don't want to exacerbate the damage, even though you're not supposed to put any pressure on the eye with this. So these are some graphics of things that you can see on the ocular ultrasound, and I'll show some videos of these as well, but I liked the graphics, so I included them as well. So retinal detachment, vitreous hemorrhage, and posterior vitreous detachment. So you can also see foreign bodies, which is here, and then on the Doppler, that's that thing over there. And sometimes people call it a little twinkle artifact. This one is a lens dislocation. So actually, I want to go back to a prior slide. So you want to make sure this is what the normal is that you should expect to see on your ocular ultrasound. So this is the anterior chamber. This is the lens, so you see like the back of it. This is the vitreous, the retina is here, and then the optic nerve is this kind of anechoic or hypoechoic area in the back. So now if we're looking at this lens dislocation video, you see that this lens has kind of floated back here instead of being here where it should be. So it's displaced from its normal position. This one is retina detachment. So you remember in the normal, the retina is just like back here, and now you have a little line, that's hyperechoic line that's kind of flown off over here, but it's still attached at the back. So it's tethered centrally to the optic nerve, which is back here. This one is vitreous detachment. So again, you have a hyperechoic linear floating structure, but unlike the retinal detachment one, it's not attached at the back or anywhere, but it's kind of floating here, and it can look like a V shape sometimes. This one is vitreous hemorrhage, which I think is kind of a fun one because it's the washing machine look. So when the patient, so while their eyes closed and covered, then you ask them to look right and left, up and down, and while they're doing that, then you see all this hyperechoic movement within the eye. So that's the washing machine appearance in the posterior chamber. And then this video is just another one that I also liked. So it's like clothes are really rolling around in the washing machine. All right, so there's also, you can use it for starting an IV because not everybody always has easy veins to find. So you want to look in short and long axis to make sure you're in the right space and you're not puncturing the vein wall. So you'd use the step down approach for short axis, which I didn't have a photo or image of here, but I do have a long axis sort of demonstration of what this would look like. So you can see the needle coming in here, and that would be where it first punctures the first wall, and then you want to make sure you don't go through the other side. But then now you have your access. Okay. All right, so some normal versus abnormal structures on shoulder and knee ultrasound. So starting with shoulder, this is the supraspinatus in long axis and short axis with the patient in a modified CRAS position. So that's where they have their hand on their hip and their elbow is pointed backwards because that really exposes the supraspinatus. And so this one is the long axis one, and this one is the short axis. This one people call it bird's beak, but I think there's a lot of structures that can kind of look like bird's beaks. Anyway, this one is more, instead of tapering off towards the end, it should be more uniform across. So again, remember, try and remove any anisotropy from here. Make sure you're not overcalling any issue in the rotator cuff. But this is the subacromial subdeltoid bursa, and that's where you would look for bursitis. And then just some other labeling. So this is the deltoid muscle, and this is the biceps tendon. And then I didn't say this before, but normally this line or the bursa should be pretty thin. And then if someone has pathology here, then obviously it will be more obvious to find. And then, yeah. Okay, so this is a picture of some tears in the rotator cuff. So these are all articular sided. So that means closer to the bone here versus closer to the bursa that's on this end. And this is an artifact that you can see. So if there is some tissue missing here, then it kind of ends up getting reflected back more. So then it's like a double contour sign here, which can be another hint that you've had some tissue damage or a tear in this area. And then this is another, some more images of tears. So again, these are partial thickness and articular sided because they start on this side and they don't go all the way up there. And this double, I think I said double contour, can also be called double cortex or cartilage interface sign, but that is another sort of artifact. And then now we can look at the knee. So this is the suprapatellar. So you can see your kneecap here. And then here you've had your quadriceps tendon, your prefemoral fat pad, your quadriceps fat pad here. And then this is normal, so you really shouldn't see much of a anechoic or anechoic line here, which would be the suprapatellar joint space. And then this one, someone has more of that space here, so it's obvious. So normal, less normal. And then we're going to do some, or I'll show you some example injections under ultrasound guidance. Again, I recommend watching the Introduction to Ultrasound Guided Procedures video if you have not already. Lots of great resources that we have for you. So this one is a knee, intra-articular knee injection. So this is the femur. This is that joint space that's very obvious in this short axis view, but the needle's coming from the lateral aspect going into this space. And then you could see this hyperechoic sort of fluid moving around in there is proof that you're in the right space when you're injecting. And if you guys need me to show those again, let me know. This is first of the shoulder injections that I wanted to show you. So this one is the glenohumeral joint injection. So your glenoid is here, the humeral head is here, your labrum is here, and this is the space that you want to get into with the needle. So you're, again, starting laterally and you go into here. But you don't want to go all the way over here because you don't want to puncture the labrum, but in here is the goal. And then you should see your fluid going through as you inject, like that. It's a little burst. And then this is the other shoulder injection that I wanted you guys to see, is the subacromial subdeltoid bursa injection. So remember, normally, so this is that bursa right here. And in normal cases, it will be pretty hard to see. Usually in pathologic cases, it will be more obvious. But you can see as they were injecting first, there was that hyperechoic kind of bubbling or movement of the fluid, and now you're seeing that bursa actually expand or distend as you're filling it with your injectate. And that one's also, you come in laterally, go medially. Oh, sorry, I didn't mean to make all of these individual bullets, but I had a lot of references. And I like to end with cartoons. But basically, some key points would be ultrasound is a really useful tool, has a lot of applications. It can help, it can be accurate, it can decrease pain, decrease patient cost, it can improve your efficiency. And there's a lot of, it's really great tool for guiding your procedures. And keep practicing.
Awesome. Thank you, Dr. Sheng. We'll open it up to the Q&A. So if anyone has any questions, feel free to put them in the chat, or you can unmute yourself and ask if you want. I'll start off first. Dr. Sheng, where would you say that you had the most opportunity to practice? Because I have had some practice, but I can see it definitely just takes a lot of practice to get familiar with the different structures that you're going to see in different sites.
Yeah, well, there are a number of options. Like if your institution has ultrasounds in clinic, and if your attendings are open to it, then you can see if groups of you are interested in practicing together outside of clinic hours, then that's a great way to do it. Also, if you are able to use it in clinic, if you happen to have time, then if you can just place the probe on anybody that you have time to do that, then that's a great way to practice as well. But I think also watching all the ultrasound videos from AMSSM and rewatching them, because I have definitely either forgotten things or picked up on new things each time I've watched it. So lots of great resources, and I keep finding more and more ultrasound websites. So I think if you look, you'll definitely find a lot.
Cool, thanks. Another question is, do you think there's any noticeable clinical difference between the mobile ultrasounds, like the butterfly ones, which are pretty popular right now, which are awesome, you can plug it into your phone or your iPad, versus the larger machines that are seen in clinics?
Mm-hmm. Well, I guess for larger machines, you also have older ones and newer ones, right? But I do have a butterfly. I got it more because I wanted to practice, and I don't think the quality is as good as some of the ones that we have in clinic, but I think for simple things, you can get the job done. And like I said, if you can use it for practice, then it just increases the amount of times that you're practicing scanning. And then there are different mobile or portable ultrasounds as well. But the butterfly is the one that I have. I haven't put in money to buy some more for myself.
I had a question.
Yeah.
So kind of going off of that, I had thought about getting a butterfly for practice. Do you think it's sufficient for practice?
Yes.
Thanks.
It's also the cheapest option.
Right. Okay. Thanks.
I have a question as well. With ultrasound and using it in sideline sports medicine, what has been your experience like using it? Are there like nuances, or is it simple as just like putting it on them and seeing if they tore a muscle or something?
I did bring it to the sideline for some of my high school football coverage, and I can't say that I ever saw anything super obvious, but it was reassuring that I had the tool, and then the athletes also really liked seeing it and kind of being involved in that aspect of their care too. When I say super obvious, I mean super obviously wrong.
All right, we'll make a last call for any other questions. If anyone else has anything, feel free to unmute or throw it in the chat. All right, I think we'll wrap up then. Thanks, Dr. Sheng, for your time. We really appreciate it. Very instructional discussion that we had today, and a very practical use that we can all hopefully put into practice as future sports medicine physicians. I just want to remind everyone that this has been recorded, and we'll post it on the student section of the AMSSM website. So if you ever want to reference this, you can either see it there or also on the YouTube channel of AMSSM. And then just that everyone here knows, we have a few more upcoming webinars. In September and October, we'll have webinars for starting a sports medicine interest group at your medical school, and a mental health and disordered eating in sports medicine. In November, we'll hear from the Agostini Medical Student Community Outreach Grant that happened this past year. So we'll hear from the projects and events of the people who received that. And then in December, women in sports medicine, their roles in leadership and as team physicians. So thanks everyone for coming out today, and we hope to see you next month.
Thanks, everyone.